My name is Judge Fulenwider. I'm a senior athletic training major at Emory-Henry College, and my case study was conducted on anterior, lateral, superficial, and deep posterior chronic exertional compartment syndrome in a runner. CECS, or chronic exertional compartment syndrome, is an overused chronic inflammatory condition that causes the four compartments of the leg, or one of the four compartments of the leg, to become inflamed and swollen and being encaptured in the compartment itself. This causes a lot of compression, causes nerve compression, vascular compression, and muscular functioning decreases due to the lack of ability and blood flow. This is a condition that can take up to 2 years to diagnose. This is because there are so many other diagnoses that it actually can be. This is a big problem, especially because this is a condition that, if left untreated, can become severely worsened, causing complete loss of feeling and sense in the patient's lower leg. Different types of treatments that can be used for CECS. One is a fasciotomy, and the other is a fasciectomy. And I'm going to go ahead and ask, okay, well, one of you guys know the difference?
I don't.
One involved taking something out.
Right. Well, a fasciotomy is basically the surgeon taking the fascia and not removing it, but kind of releasing it from the muscle, because the fascia encompasses, or just completely surrounds the muscle, and it lays on the top of it. And what happens is the inflammation and the swelling that get entrapped in the compartments have nowhere to go. And the release of the fascia, by pulling it away from the muscle itself, helps to release some of the pressure and helps to decrease the swelling, which inevitably will reduce the symptoms of CECS. A fasciectomy is a complete removal of the fascia. Basically what they do is they go in, they take out the fascia, and they leave the affected leg open with a skin graft covering it to let it heal and basically get the intra-compartmental pressure to decrease. There is a non-surgical treatment that the Army or the military conducts, and basically it's like a active range of motion, neuromuscular facilitation, getting the patient moving to relieve the pressure and promote healing. Surgical procedure has been known to work a lot better. So my patient was a 21-year-old ex-cross-country runner for Emory-Henry College. She ran for 2 years until she began to show signs and symptoms of CECS. She was having increased pain, especially when walking up and down the stairs when running. She complained for 2 years that the pain was increasing. She went and saw a orthopedic physician, and he diagnosed her with medial tibial stress syndrome, or shin splints. He sent her home, and she started doing a protocol for the medial tibial stress syndrome. And when signs and symptoms didn't improve, she went back. Lo and behold, the only way to test for CECS is a intracompartmental stress test, basically where they stick a needle into the compartment itself, measuring the pressure and if it is elevated. She was diagnosed in July of this year, of 2014, and her surgery was late August of 2014. She has previous injuries to both of her ankles, multiple rolled ankles or sprained ankles. She has multiple knee injuries, and lower body injuries seem to be very prevalent in her past, so it predisposes her to lower body conditions. For this, I used a 4 phases of healing protocol, which basically I took my patient through 4 phases of healing in a completely personalized protocol that I created based off of her goals and wants to return back to jogging status by the end of the 4th phase. So during the first phase, I was trying to reduce inflammation and swelling and pain in the in my patient's lower leg, basically by incorporating active range of motion exercises such as TheraBand exercises with internal, external rotation, eversion of the foot, inversion of the foot, dorsiflexion, plantar flexion with resistance, starting off with the lowest level of the green band, the lowest level of resistance. For her to progress to phase 2, she had to be somewhat showing signs of inflammation and pain reduction. She had to be able to walk on the treadmill without having pain, which was a really big problem for her. Phase 2, which basically was the continuation of pain and inflammation control, was a shorter phase, just because the first phase we really centered and controlled over that, or we really centered around that. The second phase, I started introducing resistance exercises, such as increasing the band strength of the TheraBand exercises, and incorporating a higher level step up. During phase 1, I incorporated a step up protocol for on a 45-pound rubber plate, and basically I would have her do step up and step down with proper technique, with proper posture, using her arms and getting her moving. During phase 2, I incorporated more of a resistance aspect to it, and increased, based on her ability and pain level, increased the number of plates that I used. For her to progress to phase 3, she had to be close to having having no to little inflammation and pain. She did not. It was a really big struggle for her to increase intensity and volume of the sessions, and she progressed very slowly through this phase. During phase 4, basically I had her doing sport specific or running specific activities and exercises that would enable her to be able to complete her goal of being able to jog by the end of the 4th phase. My points of emphasis for this project were to incorporate pain, inflammation, and swelling reduction, neuromuscular facilitation by having her do the exercise and creating that pathway or the stimulation from the brain to the muscle to actually activate and increase in active range of motion. I wanted to work on active range of motion exercises to completely increase and enable her to promote healing in her lower leg. And core stability, core strengthening, and flexibility were 3 aspects that I really thought were an important part to this project. I noticed that her posture at the beginning of the semester, or the beginning of the project, was a little off. She had a forward lean. She kind of walked on the outside of her feet. And I noticed that she had a lot of pain when walking on the treadmill, and she also had eversion of the foot or of her feet, so she walks with her feet completely out, kind of sometimes on the treadmill, which causes her extra pain. I wanted to be able to take her through a complete protocol that worked on core strengthening and core stability by enforcing proper posture, doing core strengthening and core stability exercises such as planks, medicine ball, plyo, sit-ups, and for flexibility or for core strengthening, I also incorporated a balance aspect to it, which I actually had her doing a star drill, which is where you stand on the on one or the other foot, you do both feet at the end of it, and you actually touch each point of the star while balancing. And this really incorporates not only active range of motion of the ankle, because you're having to move around and keep yourself stabilized, but you're also having to use your core, which is a multi-joint aspect to completely keep your balance. Some limitations of my study, time limitations. We only had 6 weeks to do this project. She came to me with at the beginning of the project 7 weeks post-surgery, which basically has her doing, as her doctor gave her the orders, she was not supposed to do anything that caused her pain levels to increase. So his enforcement and protocol for her was to be able to walk 2 miles before she can really start working towards jogging again. Pain limitations, she was up and down basically the whole entire time with pain. She had at the beginning a constant level of pain, and when we started introducing and progressing phases, she would increase, and in the second to third phase, kind of in the middle of there, she really peaked at pain because I had her doing intense exercises and was progressing her very fast because of her goal, and she wanted to progress, at a fast pace, which she actually wound up peaking at about an 8 out of a 10 on a numeric pain scale, which she actually said was similar to the pain that she had pre-surgery. Problems that occurred, her having the pain that she did, enabling her not to be able to do the workout session on 2 special occasions. She came in and the pain was so severe that she could not complete the exercises. So I had her do some cryotherapy with ice bags, and I had her go back and relax and rest, and gave her an extended weekend, which by the time the extended weekend was over, she came back with a lessened amount of pain, and she really started, leveling out with pain, and the pain was starting to go away, and she was having more ability. And then when we increased in between phase 3 and 4, she peaked again, and we had to once again stop the process and give her time to rest. So my conclusion, the results I got were she increased on every active range of motion measurement that I took, whether that be eversion, inversion, dorsiflexion, plantar flexion. She increased on every aspect. She ended up being able to jog for up to 2 miles on the treadmill, which was, exceeded my expectations, exceeded her expectations. And I found that limited active range of motion ability causes more pain and inflammation to accumulate in the area, especially when you have improper posture and technique when running. You make yourself susceptible to CECS or injury, and the incorporation of all of my points of emphasis that I said before, pain, swelling, and reduction of inflammation, basically eliminated her signs and symptoms, which in turn helped her get past the CECS. So in turn, does limited active range of motion ability predispose a runner to CECS? Yes, it does. Because of the inflammation and swelling that accumulate. Any questions?